Heart rate dropping, pressure bottoming out. The toxicologic patient is crashing. In the 1970s, clinicians facing this chaos relied on the coma cocktail. They pushed 50 milliliters of dextrose, 100 milligrams of thiamine, and 2 milligrams of naloxone into every comatose patient, hoping to reverse the decline. This text details syrup of ipecac, an extract of the Cephalaeus ipecacuana plant, which was once paired with that shotgun approach as a universal pre-hospital nec to induce vomiting regardless of the poison ingested. Today, clinical toxicology relies on precise pharmacodynamics. We identify the specific molecular mechanism of the poison and target the exact receptors and pathways it disrupts. Rapid bedside testing for blood glucose and oxygen saturation allows clinicians to abandon blind protocols. We now deploy highly individualized therapies based on the exact toxidrome presenting in the emergency department. To manage these critical patients, clinicians categorize their rescue interventions into 3 rigorous mechanistic pillars: binding the toxin, blocking the receptor, or bypassing the metabolic blockade. The first pillar, bind, neutralizes the threat by sequestering the drug before it can execute its physiological damage. Historically, clinicians pumped activated charcoal into almost every overdose patient. Now, we know its efficacy is strictly governed by the specific physiochemistry of the drug and the precise timing of ingestion. This is the fails mnemonic, outlining absolute contraindications where charcoal provides zero benefit. Toxins like heavy metals, caustic acids, and rapidly absorbed alcohols do not adsorb to charcoal matrices. Giving it in these cases only risks aspiration pneumonitis. Conversely, this past mnemonic lists the specific pharmaceuticals that do adsorb effectively. Drugs like antimalarials, barbiturates, and carbamazepine form stable complexes with the carbon surface. Some of these drugs undergo enterohepatic circulation, continuously reabsorbing into the bloodstream. Disrupting this cycle requires massive doses of multi-dose activated charcoal, often a 10-to-1 volume ratio of charcoal powder to drug mass, to actively pull the toxin back into the gut lumen. Enteric binding works for pills, but severe envenomations require systemic neutralization in the serum. When a rattlesnake injects a complex mixture of cytotoxic and hemotoxic proteins directly into the tissue, gastrointestinal decontamination is entirely useless. The intervention here is crotaline polyvalent immune fab, or CroFab. These are ovine-derived immunoglobulin fragments, cleaved of their Fc portions, that circulate in the bloodstream, locate the venom proteins, and physically bind them into inert complexes. This algorithm shows dosing ignores patient weight. Clinicians administer 4 to 6 vials, titrating to effect, seeking halted swelling and improved coagulation. Once controlled, they start maintenance infusions of 2 vials every 6 hours to catch slowly leaking venom. The bind strategy succeeds because it physically removes the toxic weapon from the physiological battlefield, neutralizing it before it ever reaches a target receptor. When a toxin has already reached its target and triggered a systemic crisis, we shift to the second pillar, block. We must intervene directly at the receptor level. The classic paradigm for this approach is catastrophic cholinergic toxicity, often triggered by agricultural organophosphates and carbamates. This diagram shows the precise mechanism. Top right, the organophosphate molecule inactivates the acetylcholinesterase enzyme. The synapse rapidly floods with acetylcholine, triggering a lethal overstimulation. To rescue, we deploy atropine. Atropine locks into the muscarinic receptors, competitively antagonizing them and shielding the end organ. This requires an aggressive, exponential dosing strategy. Clinicians double the atropine dose every 3 to 5 minutes. The clinical endpoint is not a normal heart rate. It is the physical drying of pulmonary airway secretions to prevent the patient from drowning. Yet, atropine has a fatal limitation. It only shields muscarinic receptors. It does nothing to fix the underlying enzyme inhibition, leaving nicotinic receptors exposed to paralysis and the patient vulnerable to respiratory failure. To survive the poisoning, clinicians must administer a second agent, pralidoxime or 2-PAM. It actively regenerates the acetylcholinesterase enzyme by physically breaking the organophosphate molecule away. This intervention operates against a ticking clock. If the covalent bond between the organophosphate and the enzyme is left too long, it permanently ages, rendering the enzyme irreparably destroyed. Blocking a toxin requires a synchronized dual-pronged attack, shielding the vulnerable end organ from immediate failure while actively repairing the underlying enzymatic machinery. Our final pillar is bypass. When a toxin disrupts deep intracellular metabolism, physically blocking a surface receptor accomplishes nothing. We must shift the cellular metabolic substrates entirely. In an acetaminophen overdose, normal metabolic pathways saturate, forcing the drug to generate a highly toxic byproduct called NAPQI. NAPQI depletes the liver's glutathione, triggering cellular death. To bypass this, we administer NAC, which acts as a reservoir to directly neutralize NAPQI and regenerate glutathione. Maintaining this bypass requires a grueling pharmacokinetic match against the toxin's half-life. Clinicians must commit to either a 21-hour continuous intravenous protocol or a 72-hour oral regimen. In a second bypass scenario, severe toxicity from calcium channel or beta blockers starves the heart of energy, resulting in a weak, barely contracting muscle. These agents induce a profound state of hypoinsulinemia and carbohydrate starvation. The heart is physically intact, but completely deprived of the fuel it needs to generate a contraction. This illustration demonstrates the radical solution: hyperinsulinemia euglycemia, or HIE therapy. Clinicians push massive, continuous boluses of insulin and dextrose into the patient. This forces the myocardium to switch entirely to carbohydrate metabolism. As glucose uptake improves, cardiac contractility is rapidly restored. The bypass strategy concedes the initial toxicological breach. Instead of fighting the drug itself, it engineers a metabolic detour around the specific physiological failure state. This matrix summarizes the interventions used to manage toxins at the molecular level, mapping out our primary mechanisms for neutralizing or opposing toxic effects. With activated charcoal and crofab, atropine and 2-PAM, and NAC and high-dose insulin, we have targeted specific countermeasures for highly complex poisonings. Yet we must respect the absolute limits of pharmacologic rescue. Some toxins evade every pillar we have built. This Persian medical protocol outlines the management of aluminum phosphide poisoning. Known as the rice tablet, it exposes the stark boundaries of our pharmacological tools. Upon ingestion, the tablet reacts with gastric acid to release phosphine gas. This gas rapidly permeates the body, catastrophically disrupting mitochondrial function across the heart, lungs, and kidneys. There is no specific antidote. There is no chelator to bind the gas, no receptor to block, and no pathway to bypass the mitochondrial collapse. Without the triad, patient survival relies entirely on aggressive, purely supportive physiological care, hoping the body can clear the toxin before the organs fail. Effective clinical toxicology depends on the rigorous application of mechanistic logic. Whether titrating ovine Fab fragments in the serum or pushing exponential doses of atropine into a failing airway, success depends entirely on understanding exactly where and how our interventions intercept the poison.